My presentation was about new appropriate use recommendations for Donanemab. Appropriate use recommendations, or I'll abbreviate as AUR, are intended to help guide clinicians who are interested in translating novel therapies into their clinical practice. And they really fill a gap between clinical trial results and real-world care. So the safety and efficacy of drugs are established in clinical trial populations, but we know that in the real world, patients tend to be older, more diverse, have more comorbidities, be taking more medications. And importantly, I think especially with this class of anti-amyloid antibodies, the clinicians who are prescribing the medications may be less familiar with this class of drugs and their potential toxicities as well. And so the AUR really are meant to complement the clinical trial publications, the FDA prescribing information, marketing materials from pharmaceutical companies, and provide an independent academic perspective on which patients might be appropriate for the drug and what are some methods for implementation that really ensure patient safety. And so the Alzheimer's disease and related disorders therapeutic work group is a group of experts in the field, people who are engaged in clinical trials or are experts in biomarkers or imaging, who have come together to try to develop these recommendations and really guide prescribers in the safe use of these drugs. And I really emphasize safety because we know that anti-amyloid therapies are associated with potential risks, including amyloid-related imaging abnormalities or ARIA that can present with edema or hemorrhages in the brain. And so I think it's really important to be very thoughtful about which patients might benefit from treatment, which patients are higher risk for having these side effects, which are usually asymptomatic but rarely can be serious. And there have been fatalities associated with ARIA with the class of anti-amyloid antibodies, including with Donanemab. And so really the AUR are designed with a little bit of a conservative approach, honestly, towards prescribing that emphasizes patient safety as we roll these drugs out. So this has been done previously by our group for the two other approved antibodies, aducanumab and lecanemab, and now we have Donanemab. Donanemab is interesting because the phase 3 clinical trial, Trailblazer-ALZ 2, included a number of innovative aspects that I think have advanced the science of precision medicine and Alzheimer's disease, but also may be challenging to implement in clinical practice. First, the Donanemab, the Trailblazer clinical trial required positivity on not just an amyloid biomarker, amyloid PET, but also on tau PET. And in fact, patients who had no tau or very low tau on PET were excluded from the trial, and patients were stratified in the trial into those that had low to medium tau accumulation on PET and those that had high tau accumulation. And there were differential response rates in terms of clinical efficacy. So that is one challenge, since tau PET is very new and not really readily accessible in clinical practice. The other innovative aspect of the trial was that the duration of therapy was titrated to the response of amyloid lowering on PET scans. So patients had PET scans every 6 months, and when they met certain stopping criteria, based on both a quantitative assessment of the amount of PET binding and a visual interpretation of the scan as negative, then treatment was halted and they were actually switched to placebo. And that happened quite often. So over 50% of patients met the stopping criteria within 12 months, and about 3/4 met the stopping criteria at 18 months, which was the duration of the trial. So by the end of the trial, only about 25–30% of patients were still receiving active drug. Even those randomized to the active arm were receiving placebo. So how do we translate that clinical trial design into clinical practice? And I think the main take-home message for neurologists and other prescribers is that the appropriate patient for Donanemab treatment is similar in terms of their clinical stage to the patients that were included in the clinical trial. These are patients who have mild cognitive impairment or mild dementia, meaning that they might need they're either independent with activities of daily living or might need some assistance with more difficult tasks like managing appointments, finance management, and things like that, but they're independent with basic activities of daily living. And this corresponds to clinical stage 3 or 4 in the new Alzheimer's Association criteria. The MMSE range that we defined was 20 to 30, which is very similar to the range that was included in the clinical trial. That was 22 to 30, so I'm sorry, 20 to 28. So we've elevated that at the top of the scale a little bit compared to the clinical trial. But the main take home is that these are patients in early symptomatic stages of Alzheimer's disease. There's no role for treating patients who don't have cognitive symptoms or who have subjective symptoms but don't have objective evidence of impairment on neuropsychological testing. And there's no role for treating patients who have moderate to severe dementia, meaning they need assistance with basic activities of daily living or are dependent. We do require confirmation of amyloid pathology. That's what the drug is targeting. In the trial, they used amyloid PET, and they used a quantitative threshold. In real-world practice, amyloid PET is interpreted using visual reads, and so an amyloid PET scan with a positive visual read would qualify a patient for treatment, or a CSF study. So in the CSF, you can measure the levels of the A-beta 42 and phospho-tau 181 proteins, and there are ratios, clinically approved, FDA-approved tests, in fact, for CSF assessment that are usually based on ratios of phosphorylated tau to A-beta 42 or A-beta 42 to A-beta 40 that are very highly predictive of amyloid pathology in the brain. And so CSF or PET are enough for qualification. One